pleased to be doing this. So by way of introduction, so market shaping is a term that's used across global health institutions, but not always with the same meaning. As the Global Fund launches its next-gen market shaping strategy, and the Gavi board expected to approve an updated market shaping strategy this July, questions are sharpening around who does what. How upstream access planning and market interventions differ from downstream financing and procurement scale-up, for example, and why that distinction matters for access outcomes. With donor assistance less reliable as a sustainability lever, affordability matters more than ever, of course, and that makes addressing IP monopolies increasingly urgent alongside the question of how civil society holds this architecture accountable. So I'm very pleased to introduce our two presenters today. Sharon Ann Lynch is the co-director at the Center for Global Health Policy and Politics at Georgetown University. She has deep expertise in access to medicines, intellectual property, and the institutional landscape of global health. Sharon Ann is a longtime friend, of course, of the access community. And I'm also pleased to introduce Agrata Sharma. Agrata is also at the Center for Global Health Policy, where she is an associate. So we look forward to a rich discussion with contributions from many of you on the call. So Sharon Ann and Agrata, please take it away.
Thank you so much, and thank you all for joining, and appreciate the opportunity to talk today, given everything that is going on in the world, as Liza said, in terms of governance. Next. So this is not a short presentation, so I hope everyone gets comfortable. We'll be walking through the definition, some of the interventions, the various actors, some case studies, and of course there are more case studies in the extra slides, principles and best practices, and just a reflection on trends in the ecosystem. Our methodology for this was using, a bunch of personal notes given our awareness and engagement on these issues, some desk reviews, especially some of the recently published articles and guidebooks that have been out that I'll refer to, and interviews with 10 global health actors and a handful of key informants. And thank you to those that are on the call among the key informants that gave your time. I do want to disclose that I am a member of UnitAid's board and I represent the NGO delegation. Next. So as Liza said, there are a number of different definitions out there for market shaping. My favorite is the one in the bold. So market shaping is the strategic use of financial and non-financial interventions to correct market failures, influence prices, supply and demand, and create healthy, competitive, and sustainable markets for health products and LMICs. Now, I happen to die a little every time I use the word market, when really we're talking about people in need. There are two recent publications that I'd like to point out. One is by Wagner et al. That includes some authors from various global health actors working in the space, and then a very detailed CHAI guidebook. There are other resources available on the last slide that we'll get to. Next. So we're going to be going through some of the various interventions, but you can also consider that they are in buckets. And these are the buckets that Wagner et al. Pointed to, which we'll be walking through with the various interventions. But it goes up and down the end-to-end pathway in terms of drug and tool development and reaching people. Next. So let's start. I know there's a lot of information on this slide, but I'll just be going over the intervention and basic description. So we are aware on this call of voluntary and non-voluntary licenses. That key actors here are mostly on the voluntary licensing, but not only. You've also got governments that can issue non-voluntary licenses, as we know. Volume guarantees, this is increasingly used as a tool. Sometimes it's unfortunately seen as a magic bullet. It is not, but volume guarantees have been helpful in terms of securing supply. Procurement guarantees is a commitment that you're going to procure. And so you see a lot of the pooled procurement actors provide those. Then, of course, pooled procurement is itself an intervention. So too is setting a ceiling or a reference price. So a number of the pooled procurement agencies do this. Tiered pricing is what we see from originator and generic companies providing different prices, either according to country income level, or sometimes you might see it being more arbitrary. Price negotiation is direct negotiation, trying to use whatever leverage you have, including some of these interventions, but not only, between the supplier and the global health actor. But of course, governments are going to be increasingly important here in this role as we transition decentralizing procurement power down to regional and country. Then science-based cost optimization. This is both evidence-based policy in terms of the cost of goods that are determined. And we have all used those as levers in order to bring about an affordable price. But there's also efficiencies to be gained in the manufacturing process. So we see actors like Medicines for All developing some of those manufacturing efficiencies. And CHAI has been very active in that space as well. Next. On the demand side, there's, of course, demand aggregation that we all know. There's the very important role of WHO and others in terms of providing forecasting and market intel in order to signal demand, but also to try to make sure that there's adequate supply. Advanced purchase commitment, there's country introduction support. Different actors play different roles here, but you're going to see how important it is to successful work and market shaping. And of course, civil society and advocacy, we wouldn't have products if there weren't people affected by the diseases that are making demands for access. Various risk sharing instruments, and it includes some of the guarantees that have been mentioned that are used by different actors. The pre-financing in terms of revolving funds is very interesting. We'll talk about that, but you've got some of the actors that use that. That will become even more important again as countries transition from pooled procurement to national and even regional, to tell you the truth. Buy-down agreements, we'll give some examples of those. That's where a donor will provide cash on the table in exchange to lock in an affordable price, or that is the goal. Next. On the demand side, I'm not going to go very much into this, but you've got product development and incentives and you see some of the actors working in this space. Push funding, of course, that R&D grants, and then some pull incentives. These are used less so than grants, but hopefully we'll see an increase there. Regulatory harmonization is critical, and you know of the efforts underway, especially at the regional level. Regional manufacturing support, I'm not going to go too much into this, but I do have one slide in the extra slides that goes through what some of the different actors are doing and what's missing. And then on the R&D side, market intel and transparency are very important in terms of generating R&D capacity. Next. Now, of course, all of these interventions do not take place at the same time. So I found this diagram from CHAI very useful in terms of where different interventions might be used across the pathway, that time to population pathway. So through our presentation, we'll be emphasizing sometimes price, but also sometimes the speed of which an innovation can reach people in need. Next. I found this from CHAI also very useful, both their decision-making framework as well as the conditions for successful market shaping. So you decide whether there is market failure, you identify the barriers and conditions that can be addressed and create a competitive and sustainable market. You activate the market with activist organizations who can align the ecosystem and aggregate that leverage and orchestrate the market shaping interventions. CHAI themselves has played this role many times, as have some of the other actors. Determine if a financial tool is needed, if one of the interventions that falls into the financing bucket is needed. And then, of course, scale and grow demand for the product, because obviously the work does not end with securing a low price. And we're going to see greater examples of that. Next. So I'll be talking a bit more about Unitaid, but I wanted to highlight the range of interventions that Unitaid has used in the past to secure either affordable prices, healthy supply, and demand. They're one of the few actors that works on demand generation in addition to focusing on the supply side and work early upstream. Chai, of course, their guidebook is very interesting in terms of looking at particular case studies. They have a number of tools in their toolbox. Gavi as well, you can see here, and we'll talk a little bit more. The Global Fund, I'm going to get into a bit more later. And then the Gates Foundation, the private philanthropic organizations have probably the most latitude when it comes to the tools in their toolbox. They're very robust. They can do a lot of things. And then UNICEF Supply Division and PAHO, they've got the pooled procurement, supply security monitoring, also stockpiling in the cases of emergencies, which are critical and become more critical as countries transition from pooled procurement or donor support. Next. Some of the other actors, I don't have ARM on this slide, but I want to flag that ARM is another global health actor that is becoming increasingly active in the market shaping space. But MedAccess, they are interesting because they're funded by UK government. They provide volume-based guarantees, some with royalties that are paid back by the suppliers. Some of those royalties can be negotiated down to a very low amount, which is good. They provide loans and financial backing to secure financing for suppliers and provide CapEx loans. They have also provided procurement guarantees and otherwise de-risk supply to shorten lead time. So this is all very important, especially because of problematic financial flows within a country to be able to place orders. CIF has a robust toolbox as well. So whether it's volume guarantees, they have topped up various catalytic procurement interventions, for example, like Unitaid. They provide support for new products introduction, which we'll talk more about. They are funding the Access Fund at the Global Fund, which is part of the next generation market shaping strategy. They also provide CapEx to reduce the COGS for the cost of goods for manufacturers and have provided matching funds, and they fund demand generation. We're going to be going through more the APPM, and I just want to thank Public Citizen for having the African Pooled Procurement Mechanism on a call earlier this year that was very informative. And of course, their role is only going to increase in the ecosystem. Now, USAID, which doesn't exist any longer, many of their supply folks did move over to the State Department, but we all know that the State Department is also sunsetting one of the largest contractors, Chemonics, for procurement and supply. So this signals to us that their role will be diminished in the space. And of course, only time will tell. But they have been, in addition to providing earmarked and set-asides for regional production, very active in the space, even including on the R&D side. GDF we'll talk more about, but I do want to flag this long list that didn't even fit in the box of the interventions that they use. They really have an end-to-end focus, and I flagged this because they're among the calls for consolidation and changing the global health architecture. There are rather simplistic notions that some of these organizations can simply merge, that the Global Fund can take on what GDF does, but GDF, I just want to flag, does an awful lot more than just pooled procurement. Then the Medicines Patent Pool, I think we're all familiar, but they do a lot of work beyond voluntary licensing and should be recognized for that work. Next. In addition to the individual actors, there are many platforms for coordination. Many of these are ad hoc. Some have been in existence for a while now. I want to give the example of one that I've been involved in, which is the TB Procurement and Market Shaping Access Team. It's quite something when you have governments, global health actors, and civil society in a room coming up with target prices. So this happened for a regimen basis for drug-resistant TB, but it's also happened for individual drugs. Then the actors do various things and communicate with each other in order to try to secure that target price. There have also been joint calls of TPMAT with a supplier. So you have some of the big procurers in the room, along with global health actors, talking directly to manufacturers about needs. Sorry for going too fast. I'll slow down. Next. Over to my colleague, Agrata.
Hello, everyone. I'm Agrita, and thank you, Sharnan, for taking us through. I will be talking about one of the actors in the global TB procurement space, the Global Drug Facility, or GDF. GDF was established in 2001 and is hosted within the Stop TB Partnership. GDF is today one of the single largest procurer of TB commodities, covering diagnostics, prevention, and treatment across the complete cascade of care, basically. Its end-to-end market shaping, as Sharnan mentioned, or management approach operates across three distinct functions. The first being market shaping and supplier confidence. So GDF places monthly stockpile orders that keep the production sustainable financially for the manufacturers. This provides market stability. It also absorbs small pediatric batches and ensures suppliers don't lose money on niche products. And it basically functions as an implicit guarantee of sorts for formulations and commercial markets that would otherwise be abandoned. And it supplies any country in need, regardless of their income level. Second,
Sorry, this is Liza. Just jumping in to ask if you would please just slow down a little bit.
yes, sorry.
Yeah.
Second, policy coordination. GDF coordinates across WHO essential medicines list. And WHO pre-qualification, Global Fund, expert review panel processes to streamline and accelerate product entry, collapsing what would otherwise be sequential regulatory steps. It also created what's called the wasting policies to protect national TB program budgets during dosing changes, preventing the budget shocks that can derail treatment programs mid-transition. And then just a little bit about forecasting that GDF does. It uses a tool called QuantTB. QuantTB is an open access demand forecasting tool that allows countries to project needs up to 2 years in advance and identify future stockouts, other risks, and the data is collected on a quarterly basis from countries and aggregated into global supplier forecasts, which is critical for keeping manufacturers in the market. Third is sustainability. GDF manages a deliberate graduation model where large countries or countries with high burden of TB are supported and towards procurement independence, while small countries or countries that are, that have a lower burden of TB are kept in its system and are retained for long-term specialized support. For countries transitioning to domestic financing, GDF continues to function as a safety net for emergencies, backstopping supply even when formal support winds down. So basically, what I'm trying to say here is that it isn't just bulk purchasing mechanism. GDF actively works to shape the markets it operates in. It's not, a model wherein if you need it, we will supply it. It includes demand forecasting, pooling procurement, negotiating prices, and supporting countries with quantification. And of course, like what Sharnan mentioned before about TPMAT is quite interesting. And then I'll just move on to Gavi. I think most of the people on this call would know everything about Gavi, but I just wanted to say a little bit of stuff about it. So it's the second actor that I'm going to talk about. So Gavi's market shaping toolkit operates again across three different areas. On the demand side, we have the advanced market and procurement commitments that are the most critical instruments that reduce the commercial uncertainty for manufacturers even before demand materializes. UNICEF-led procurement aggregates large tenders to ensure lower prices and reduces market fragmentation, while multi-year contracts provide funding visibility for manufacturers, which they need for long-term planning. On the supply side, Gavi promotes multiple suppliers and geographic manufacturing diversity, with competition as the primary price reduction mechanism and premium allowances being allowed for locally manufactured vaccines. Market shaping decisions in each of these cases are structured through the healthy market framework. And based on one of the interviews, we got to know that the sixth version of it is being finalized as we speak. And for outbreak, epidemic, and pandemic pathogens like Ebola, cholera, mpox, and emerging threats, Gavi maintains an outbreak epidemic prevention stockpile, which are critical where unpredictable demand would otherwise undermine any commercial incentive to maintain supply. On the slide, we have two examples to showcase the good and then not so good impact of Gavi's market shaping efforts. On the Ebola vaccine side, there's a relatively better story. Gavi's 2016 APC incentivized Merck to pursue licensing and maintaining emergency doses, a first of its kind mechanism. By 2021, Merck, UNICEF, WHO, and Gavi, so a bunch of actors, had established world's first Ebola vaccine stockpile, which now holds roughly 500,000 doses of several, outbreak and pandemic vaccines. The arrangement is really interesting. So basically, Merck supplies the vaccines at cost. Gavi finances the stockpile and deployment, improving both the demand health and outbreak readiness. The incentive alignment here is a model, in my opinion, that is worth carrying forward. On PCV, the tale is a little more cautionary. Launched in 2009 with the goal of preventing 7 million childhood deaths by 2030, PCV AMC were criticized by the likes of MSF very early on. And the criticism has held up. The vaccine had existed since 2000. The barrier was not the product being absent from the market, but it was the price. The AMC did not accelerate the development timelines. Instead, it entrenched the first movers, that's GSK and Pfizer, by giving them 82% of the total funds that were available, while the likes of Serum Institute of India just received 5% a decade after the PCV project was launched, resulting in persistently high prices. Underlying this was Gavi's broader policy stance, not pushing for technology transfer and not working against patent protection. Those choices had consequences beyond PCV. By not acknowledging the shortcomings of PCV's AMC, the same model was replicated during COVID-19 pandemic and became the blueprint for COVAX, exacerbating the inequities. I'm sorry if I still went too fast, Liza, but over to you, Sharnan.
Thank you. Next slide, please. So I'm going to be talking a little bit about Unitaid and some of the other actors. So Unitaid recently commissioned an analysis of the ecosystem and Unitaid's role in it and found that they were both unique in some ways and very much needed. Considering that Unitaid's role unique in working on access and early introduction stage, essentially bridging development, product development, and large-scale delivery. So their work also is focused on evidence generation, some of that feeding into WHO guidelines and informing implementation. They also have a heavy focus on the demand side, which again, you're going to see how critical that is to successful market shaping. One of their rare roles, especially in this ecosystem, is addressing IP barriers through their funding role, but also their pathfinding role and their convening role. So they essentially enable scale up by others in terms of reducing the cost curves. That's the cost per person per year, but also the cost of delivery and whatever burden on the healthcare beneficiary themselves. Next. So the APPM, I just want to focus or highlight their dual role, which is from their slides earlier this year to improve access to quality and affordable products, but also to work as a demand side mechanism for African manufacturing. So they are adamant that this is not just buying and selling. They are not just a full procurement, and they will be playing more of a substantial market shaping role as both the financing capacity and opportunities exist, but that all hinges on demand. They are working towards the goal of the AU goal of 60% of health products from African manufacturers by 2040, with that essential midpoint by 2030. So you see some of the interventions here. Next. Now, the Global Fund, I'm sorry, slide is, well, sorry for the presentation being fuzzy for some of you. There's a lot of information here. So the Next Generation Market Shaping Strategy, their work started in the grant cycle 7, so essentially the period of 3 years. Going into GC8, grant cycle 8, is now over the next 3-year period. So there are some new interventions that the Global Fund has used. It has a revolving fund that is funded by the Gates Foundation that enables it to provide advanced volume guarantees in the example of malaria bed nets. Also providing co-pays, and this is the Access Fund within their market shaping strategy that helped with this. That Access Fund, as I mentioned, is funded also by CIF. That allows for co-pays in the case of lenacapavir, the new near point of care tests for TB, and alternative ACTs. What will be in front of the board in July is whether the Global Fund will also set up a pre-financing facility. So a revolving, so in order to allow for countries to purchase on credit. This will matter a whole lot, not only for countries that are required to co-finance some of their procurement, but obviously for countries that still choose, that would like to use WAMBO as they transition off of Global Fund funds. What they can't do is provide financial support to manufacturers. So some of the critical interventions that you've seen by Unitaid, which we'll talk about, by CIF, by the Gates Foundation, by MedAccess, although MedAccess does in the case of loans for providing CapEx. This is something the Global Fund cannot do. What the Global Fund, unlike some of the other actors like Gavi, also doesn't have a target for locally made, regionally produced goods to provide overall, to procure overall, but also in the regions in which they're supporting. But local manufacturers do get scored for being local, for regional, in terms of scored for the location throughout the tendering process. So while there's not a premium price allowed, you do see some flexibility there in the scoring. Now, there are some concerns about this expansion. One, in terms of the Global Fund procurement role. Given that, what about the conflict of interest when acting as a market shaper? There's also scope and eligibility gaps. Will the Global Fund's market shaping role focus only on countries that are eligible for funding, which again is going to winnow and winnow more over time? And or does it include the countries that use WAMBO, or that can they consider all LMICs in terms of their market shaping goals? There are also some operational constraints, and they are not the only ones that have annual funding cycles, to be sure, but that could inhibit some multi-year market shaping commitments. Also, WAMBO, unlike GDF and UNICEF, they're unable to warehouse goods, so especially to respond to emergencies and acute shortages, that would be critical. And as the U.S. government might be looking to WAMBO to take up what Chemonics ends, where Chemonics ends, it's important to figure out where are we going in terms of American first questions and how much the Global Fund will have to bend in order to meet those priorities, whether it ends up being a requirement or not. And then in terms of strategic clarity, it does need to be asked, what is the added value of WAMBO over UNICEF's supply division? Obviously, if they allow countries to purchase on credit, that's a big thing. And then the question of added value of market shaping over other actors with a much longer track record that have had 20 years to learn from their mistakes, let's say. Next. We're going to be going into some case studies now, so I hope people don't get bored, but I find it all very interesting. Next. So let's start with lenacapavir, one of the most recent examples of market shaping. So you have Gilead and Global Fund negotiating. We don't believe any cash changed hands, let's say, or there are any concessionary offers in order to get that secret price of $100 for len per person. which then the Global Fund, using its Access Fund, was able to subsidize further to offer $60 per person per year, thanks to SIF, to countries that are covered by the Gilead license. What Unitaid did was essentially bring the price forward and thankfully not UNICEF, sorry, Unitaid and Gates bring the future price forward by locking in a $40 price from two manufacturers. So it was a volume-based guarantee from the Gates Foundation to Hetero, and it was negotiation and some financial incentives for Dr. Reddy's lab. The agreement with Dr. Reddy's, I just want to flag, includes a number of things. It includes commitments to optimize manufacturing on the API side, which could further bring about price reductions that are expected. And also, there's a commitment to support regional manufacturing opportunities in sub-Saharan Africa. So this is an example where different actors played their part. I'm not going to claim that the coordination was smoothless. There were absolutely smooth. There were some actors that held close to their chest and were less transparent about the work. And there were opportunities, though, for all of the global health actors to meet with Gilead all together. Not to say that they were all on the same page, but this was the $40 deal was very welcome, especially because we had some people, even in the civil society community, say that $40, when we brought up $40, we got laughed out of the room. So that is an example of some of the actors working well together. Next, or not. Another example, and this is a bit from history, is being able to move from a fixed dose combination to dolutegravir. At the time, the standard of care with the backbone was efavirenz. That had serious side effects. And also, dolutegravir was more potent, but it was almost more expensive, and a lot more expensive, at 25% over the price of TLE. So thanks to volume-based guarantees with Mylan or Bindo, they were able to lock in a price for TLD at $75 per person. It's the first time that a new, more effective single pill reached countries at a price below the product it was replacing. Suppliers committed to a certain number so that they could make sure that there was capacity. And then there was a full court press by some of the actors, including PEPFAR and Unitaid, to grow demand for the product. And here, just like many examples, this all wouldn't have happened in terms of the uptake of TLD if not for people living with HIV and activists working at the national level. Next. So HIV self-tests, these weren't marketed in LMIC, save for, there's the rare price of $15 for HIV self-tests that was offered to South Africa private sector. Otherwise, the kit was $40 in the US. We don't have other prices because, again, it wasn't being marketed. So it was seen as also too high for governments to enter into bilateral negotiations, the price was. So what happened was Unitaid had what's called the STAR Initiative, Self-Testing Africa, that catalyzed demand across 6 Southern African countries. You had a Gates buy down to lock in a price with just one company that only had the one product at the time, a price of $2 a kit across 50 countries. That was a 90% reduction of the price that we were aware of. And Unitaid supported the route, the evidence gathering, the generation that then informed the guidelines that WHO came out with, that then saw uptake of those guidelines in more than 40 countries. I want to flag here that as other manufacturers came on, of course, there were competition played its role, and now we see prices of $1 to $3 for this test. The test has also, I have to say, been very effective in terms of the positivity rate. So more people are test positive using this test than under conventional methods. Next. Agrata?
Yeah. So this case study focuses on malaria. The case study is about the dual active ingredient nets, or dual AI nets. The innovation here was basically that the nets had two distinct classes of insecticides, ensuring that mosquitoes resistant to one kind were still killed by the second. This matters because pyrethroid resistance was real and was impacting health outcomes across sub-Saharan Africa and steadily eroding the effectiveness of the standard nets. The first dual AI candidate, BASF Interceptor G2, received WHO pre-qualification in 2017, but relative efficacy still needed to be demonstrated for a clear recommendation. Sorry. I'm so sorry, Esteban. I'm going to go slower now. So the timeline comparison that you see on the slide is quite telling. For PBO nets, the prior generation of dual AI nets, it took 9 years to accumulate sufficient evidence and another 5 years from WHO recommendation to reach 50% of global fund net procurement. So basically 14 years in total. For dual AI nets, coordinated intervention compressed that to 8 years, 7 years from WHO listing, and then just 1 year from March 2023 recommendations to meaningful scale. The contrast here is it reflects deliberate choice to run evidence generation and market shaping in parallel rather than sequentially. The intervention here was the New Nets project, a $66 million project launched in 2018 by United and Global Fund, specifically to avoid repeating the slow scale up that had characterized the PBO nets. It had two goals. First, to generate evidence for a timely WHO recommendations. So on that side, we have a consortium including Innovative Vector Control Consortium, LSHTM, Imperial College London, Tulane, PSI, PATH, and several other actors coming together to build the efficacy case. In parallel, Gates and MedAccess provided volume guarantees to BASF's first dual AI net candidate, securing volume-linked guarantees, which led to price reduction over 4 years. A co-payment mechanism from Global Fund and Unitate covered the cost gap between the existing and the new dual AI nets, enabling countries to procure them within the existing budgets. The US President's Malaria Initiative, or USPMI, provided in-country capacity building and deployment support. By 2022, more than 37 million nets had been deployed across 14 countries. That is before even the WHO recommendation was issued. This was definitely a calculated risk, but it paid off. Trials showed that Interceptor G2 reduced malaria cases by an estimated 45% relative to other nets. Modeling by Imperial College London estimated that 13 million malaria cases and about 24,000 deaths could be averted by the nets deployed between 2019 and 2022. Post recommendation, the market shaping did not stop. Global Fund allocated an additional $50 million through a Gates-supported revolving facility, underwriting volume guarantees with two suppliers, BASF and newly pre-qualified Westergaard, bringing the dual AI prices down to levels comparable to PBO. Then the countries could now basically transition at scale within the existing budget envelopes. Demand for dual AI nearly doubled in the Global Fund grants. The sequencing here, basically that running evidence generation, price negotiations, co-payment support, and transition funding, running in parallel rather than in series, shortened the time to scale. Okay, with that, I hand it over to Sharnan for Cepheid.
So many of us are familiar with the Cepheid story. So a number of actors, four global health actors, got together and put cash on the table to the tune of more than $11 million in order to lock down a price of around $10 for Cepheid's TB test. It's TB cartridge that went into the GeneXpert machines. There were a number of smart things in the contract, and I want to thank Terry Roberts and Kathleen England that first brought this into the public space, and also appreciate their critique of it. So one thing that was in the contract but that was never enforced was a price floor guarantee. If one lower price is offered to any country, it has to be offered to all countries. That did happen in the case of South Africa, but the lower price wasn't offered. A royalty clause for some of the materials that were used to make the test. Once the royalties expired, then the price should have gone down. That didn't happen. Global health actors were able to audit the cost of goods and analyze the volumes after the deal. That wasn't conducted until the deal was sunsetting, and mainly because of the pressure from Kathleen England and Terry Roberts, frankly. And Cepheid was supposed to provide a reduced price to the private sector, and that never happened as well. So some lessons here and concerns is that the volumes tripled and went well beyond what was originally put on the table in terms of estimating volumes. And yet the price didn't decrease, largely because that audit didn't happen. The global health actors didn't march back in. Also, there was some people have perceived this buy down setting up a monopoly for Cepheid, although I do want to flag that there were funding efforts, especially by the Gates Foundation, for fast followers, but there weren't any fast followers in terms of new developers with new molecular diagnostic platforms. One of the problems also was there was a robust development pipeline, but the deal did not cover any of those tests, any of the virology tests. So you have still high prices, around $15 for hepatitis C, for HIV, and for HPV. Even though it is the same mold, it is the same production line, and MSF has shown that the cost of goods is very low, on par with TB tests. Next. Now, going into the future, we've got this new molecular diagnostic test. It's the first in class. It's a new near point of care test that could be decentralized at the primary healthcare level. As part of the grant for development that Gates provided, they did have ceiling prices. You see the prices here, so that the test that goes in here for TB is $3.60. So that's less than half of the GeneXpert TB test. There are also, because of market shaping actions, further price reductions that are supposed to take place. Right now, there's a set of 13 early adopter countries of the Global Fund that, thanks to that Global Fund Access Fund, can actually purchase the test for $1.10. Now, some concerns, I should say on the demand side, there's funded work from CIF, funded work from UNITAID, and the Global Fund considers this test a program essential, along with other molecular platforms in the Grant Cycle 8, all helping to increase demand. So the pricing terms, again, we're concerned that it doesn't extend to the other tests in the pipeline. Again, there is a robust development pipeline, some further on than others. We obviously don't want to see a monopoly here, although this machine costing $155, which is one of the two devices needed, is much more affordable than the $17,000 GeneXpert machine. That was the price for when the buy down first took place. So we could probably see more fluidity in the overall use and the market on the demand side, where countries can switch over to competitors if and when they become available. The Global Fund is considering volume-based guarantees for those fast followers, given that there are developers coming with new platforms. Next. I think we're going to skip this one. We have to talk about. Sorry, guys, but I know we have a lot of case studies and I appreciate your patience, but we've been talking a lot about the role of global health actors, but there's the essential role of countries themselves, of governments themselves. And I want to flag two examples from South Africa. At one point, South Africa put in their request for bidders that they were required to provide a global access price that they would offer to all LMICs. If you see on the graph here, and sorry if it's fuzzy for some of you or all of you, there were such high prices being charged for the HIV viral load test across countries. The access price, thanks to the tender that was then awarded to Roche, locked in the price for $9.40 a test. So this was tremendous. And then there's the price negotiation that helped to benefit the rest of the world. In the case of bedaquiline, the South African government negotiated a price of $40 down from $750 per person for a 6-month course of bedaquiline. Bedaquiline was an oral therapy with fewer side effects than the standard of care at the time, and also helped to double the number of people cured as part of a better oral regimen that was developed over the standard of care that took 2 years of treatment in order to reach a cure, and obviously not for everyone. Next. We're going to skip the PEDS ARVs, sorry, Agrata, and move on. So hepatitis C, I'll just do this one quickly, Agrata. So again, you have the example of Rwanda that really led the charge in terms of bringing about lower prices for DAAs with some support from CHAI, but it was their commitment to treat that really helped lock in that lower price. Then CHAI and others went to get that price for other countries. They were able to do so. They got a commitment from 2 manufacturers, both Viatris and Hetero. But because there wasn't funding for demand, because there wasn't funding for this product, those 2 manufacturers left the deal. They withdrew. So this is a case when we've got, next, when we've got some areas in alignment, but not others. So a very simplistic way to look at it is the 4 C's for access, where is the innovation too complex? Is there community demand for it? Are the costs, are the prices affordable? And is there a high consequence? In the case of hepatitis C, you saw a 90% cure rate, but because you didn't have these other factors come in, especially demand side and funding, it fell apart. Next. Please get comfortable again, because there are a number of principles and best practices and lessons learned. So you have within strategic framing and ambition, the very important need, and we heard this from all the global health actors, to focus on the use case in context of all the tools needed and not just the single product. To aim ambitiously to secure access to health products as a global public good. And we want, as much as possible, these deals, obviously all of us know we can't keep going from one product by one product. We need to bring about a shift in the ecosystem. So I talked about Rwanda, I talked about South Africa, but if you look at other countries that support end to end from the research and development, like Cuba, like Brazil, those are the kind of changes we want to see in the global health architecture. We want global health actors with countries and civil society to develop target access profiles. I'll be going through those, and there's more information in the extra slide. We want market shaping to start early with better engagement with innovators and R&D funders that should be providing commitments and access conditions as part of contracts, obviously. And integrate the full development of delivery. So the end-to-end pathway, that time to population should be considered, not just one piece of it. In terms of pricing, the anchor pricing and evidence, we don't want to start from the high prices that a manufacturer might bring. We want to avoid, and there's an example in the extra slides, of avoiding setting a precedent when a manufacturer is clearly fishing for a buy down. They're clearly fishing for cash or financial incentives or other concessionary offers. We don't have actors focusing a lot on distributor markup, but in the case of Cepheid, even though you have a $10 price, there were many countries that were charging much more in terms of distributor markups that then saw the price be as high as $100 in some countries. We want to obviously promote competition and avert monopolies, but also to keep in mind that the market can bear more competition than we give it credit for, and more suppliers, as long as the volumes are there to justify. Obviously, as well, to enable regional production, but not setting them up for failure, and not doing harm in our regional production work to push smaller regional manufacturers out. Because they might not be able to meet lower price demands. Demand and supply balance, I think we've hit on this note a lot, but again, it's essential to successful market shaping. And also, though, we need to take care so when we ring fence demand, so funding for a particular product, we should do so when we risk scaling up of the other tools in the basket. So one example is the TB vaccine. Instead of coupling and providing ring fence funding for also TB preventive therapy, and you can say the same in terms of the malaria vaccine if there's just ring fence funding for that, as opposed to the suite of interventions that are needed to prevent malaria. Next. The durability of access conditions are important, but we need to, from the start, find synergies across health issues and pathologies. I gave the example of the molecular diagnostic platforms with Cepheid and PlusLife, but you can say the same for other platforms. So monoclonal antibodies, for example. Also, global health actors need to be, and governments need to be creative in their negotiation when it comes to negotiating with a single company. So one company might have multiple products that you want to negotiate around. We need to future-proof agreements against funder transition, policy shifts, and pipeline changes. So essentially, the contract that, let's say, is done with the R&D funder, it should be like a baton that is passed through various actors down the end-to-end pathway. We want to see benefits agreements extended to non-public sector. This is rarely included in the deals, including the deals that we've gone through to date and some of the case studies that are in our extra slides. And build in accountability mechanisms. Global health actors and governments need to look back. They need to look back at what has been done. I gave you the case of the audit for Cepheid that wasn't acted upon, but we also should be building in volume-based triggers. So it doesn't take the action of a global health actor who might be preoccupied with something else to not do the audit and to not have reduced prices. So they should be automatic volume-based price triggers. In terms of eligibility, I'm sure you all agree that the agreement should include all low and middle income countries, include civil society, commit to transparency. You know, the global health actors that we spoke to said this was difficult for some agreements and for some details, but again, we should know the details of the various agreements, and we don't. Include countries in developing the target access profiles and the negotiations. And then the coordination in the ecosystem, especially since the funding concentration, the shrinking of funding in the global health space, and especially for infectious diseases, we see actors acting more competitively. So sharp elbows are out is what we heard from many interviewees, and somewhat a claim of doing more than what has been in a global health actor's wheelhouse in order to try to lay more claim to the space in the global health architecture. Obviously, it doesn't help when you've got some actors that are putting their $12 billion thumb on the scale in terms of calling for consolidation of some of the actors, even though they aren't able to take up all of the roles of various actors. Next. I just want to flag this target access profile. This was originally called for by my colleague Christophe Perrin at MSF, and Unidata has really taken up the charge where they have been using target access profiles internally, but then as a point of coordination with other actors. So there are a number of buckets. There's a template in the extra slides, but the buckets go across affordability and pricing, licensing, tech transfer, transparency, and regulatory alignment across three scenarios, both at introduction at scale and if becomes a wider indication, which often happens, for example, with drug-resistant TB drugs. I shouldn't say often, but has happened. Next. Now, just a bit of a reflection, right? This presentation could be considered antiquated, given the changes in the ecosystem. So we've got some trends. We've got less funding. We've got fewer countries that are eligible for external funding. We've got the ascension of regional and country level health sovereignty, and that is playing out in a number of different ways and in ways we don't know what will happen yet. There is obviously a call for fewer vertical disease silos and to focus more on the primary healthcare level and UHC overall. There's less dependence on the aid architecture. There's still dependence, but the funding isn't there. But countries will be taken on, as I mentioned, some of their procurement power. That could ultimately lead to more sustainable institutional agreements and arrangements, especially, we have high hopes for the APPM. But what we might also see is, because money is not going to fall from the sky here, even though we all want to see greater domestic resource mobilization, is potentially greater segmentation of the markets and higher prices, lower supply, and issues of quality. Can you go to that slide, Agrato? So, obviously we have benefited from, in HIV and TB and malaria, from the various pooled procurement mechanisms out there, but also the fact that Global Fund requires WHO pre-qual or stringent drug regulatory or ML3 approvals. So that quality issue is important. Obviously, there are things that national governments can do to maintain high quality standards or quality standards. In terms of prices, it would be helpful if governments made the bidding process, the national requirements transparent. If they got a waiver from the national tendering requirements and process in order to continue to tap pooled procurement mechanisms, whether that be APPM, whether it be UNICEF Supply Division, the Global Drug Facility, or WAMBO, that obviously countries should utilize TRIPS flexibilities and other market shaping tools. And then on the regulatory side, I just want to flag, and I'm so sorry for those who have heard me say this a lot, but even some of the bigger countries, when they do the right thing in terms of tendering, the tenders fail. And they fail either because a company isn't interested in their country as a profitable market, or the tenders fail because the company never bothered to register their product, again, because the country might not be seen as an attractive market. So here we have lots of products that, especially on the pediatric side with the low volumes, that haven't been registered, but also even some basic TB drugs, even some basic HIV drugs that have not been registered. If you're wondering, well, how have things worked up till now? Countries, most of them utilize a waiver from the local registration requirements when a product is free. So whether it's PEPFAR, whether it's Global Fund supported, or from another external funding. So we're going to see more and more what we call procurement cliffs as we see a transition. And then on the supply side, we know that there are problems with financial flows in terms of getting cash to suppliers that have to be prepaid. But there are also, there's a lot of technical assistance that has been available to countries to help with forecasting. So once that goes away, we are probably going to see more problems in terms of having a stable supply. But it's mostly about that money, having to pay in advance, having to pay upon arrival. That's the problem. Next. I just want to say thank you for your time and attention. There are more case studies in the deck and other resources to tap if you want to learn more.